Okay, well, thanks everyone for joining us today. It's our great pleasure to welcome Dr. Ryan Brown to our seminar series. Dr. Brown has been at CU Denver since 2014 after completing his PhD in economics from Duke. His research interests span applied microeconomics, including development economics, labor economics, health economics, economic demography, and political economy. His current work is focused on applying econometric techniques to population representative data in both developed and developing country settings in order to examine how changes in the social, physical, and/or economic environment can have a persistent impact on population health, preferences, and human capital accumulation. And today he'll be sharing some of his work from his project, looking at the impact of access to clean water on cognitive and physical development. Evidence from Mexico's Programa de Agua Limpia. Ryan, welcome.
Great, thank you. Are we seeing the screen okay now?
Yes.
Looks good, okay.
Ryan, could you make it
Yeah,
Yeah, there we go.
Full
Perfect.
screen. That looks good?
That's still the same.
It hasn't changed?
No, it's probably because of the way it,
Yeah, I've seen this problem before in Zoom meetings. I don't think it will necessarily let me full screen, but it may. Does this look better?
that's great. That's
Yeah.
perfect.
Yeah. And are you seeing me flip through the slides?
Yeah.
Yes.
Cool. All right, great. Thank you so much, everybody, for coming. I'm really happy and excited to be talking with you guys. CUPC has been a really, really nice thing to get involved with here in being in Colorado and being in Denver. I spent a lot of time in my graduate studies in the Pop Center at Duke. I kind of lived there some of the times. So this is a community I really feel comfortable with and get a lot from. I've always felt that people interested in population studies are really the best at doing this sort of interdisciplinary work. And the kind of stuff I'm doing is definitely not in any way specific to economics. And so without those other perspectives, I think I'd be missing out. And so I'm really happy to share work with you. I'm going to try to do my best, even though I started late, to leave time at the end for questions, but definitely jump in whatever way we can if something's not clear. That I would like to, if there's anything that's not clear, I would really like to make it so everybody's understanding sort of what I'm trying to, what I'm trying to do in that moment. But anything more substantive, I'm happy to take later. As Adam mentioned, this is a project about clean water. This is with some co-authors, Sonia Balotra and Athena Venturami. And it's a project we're really excited about. The motivation comes from the fact that unsafe water has been linked to things like cholera, diarrhea, dysentery, among many other diseases. And in particular, it has a big impact on kids. 400,000 kids, mostly from developing countries, are estimated to die from things like diarrhea each year. And this diarrhea, as best can be told, is mostly being generated through tainted water. And this represents the second leading cause of death for children in the world. So it's a big problem. There's been a pretty comprehensive literature, both in demography and sociology and economics and epidemiology, that has done a really nice job of documenting the short-term benefits of treating water, of making your water cleaner. And in particular, the big impacts that they highlight in these short-term studies are about infant and child mortality. So we've definitely seen across many different time periods, many different settings, that if you clean water, you will improve the health of infant and children, particularly around that boundary of, are they going to make it old enough to sort of get past that high mortality, those high mortality very early years. And this has prompted major investments in safe water provision, which is fantastic. But unfortunately, still around 850 million people live without a clean source of water, which suggests that at least for some, there's still this judgment that the costs of providing this is outweighing the benefits, okay? And what really motivated this project is our belief that if you solely focus on the immediate effects of access to clean water, the policymakers that are trying to do this cost benefit analysis may be severely underestimating the total value to the economy of providing clean water. And there's a reason to believe that these larger benefits would exist, because there's a very large literature and growing literature that shows that health shocks, particularly in the first 1,000 days of life, can have persistent impacts on an individual's physical and cognitive development. And in addition, there's a robust literature showing that the positive impact of stature and intelligence can have these sort of persistent and long-term impacts into these children's adult economic outcomes. And so we've got these two widely accepted facts, which both suggest that increased access to clean water during the infancy period may have this long-lasting impact on economic growth and improve the development gap. So clearly this paper is being done in a developing country. And so potentially one of the big ways that you might be able to see a catch up in economic development would be through improving health of children. And water and clean water is a really straightforward way to potentially obtain that. So what we think is there are some really important implications here. Okay, there's still a lot of people living without clean water. Clean water has an impact on infant and child health. Infant and child health seems to have very long-term and persistent effects on economic outcomes. And so our idea here is, let's try to establish that there is this sort of connection, so that we can convince policymakers that perhaps they need to value even higher the provision of this clean water. Okay, in terms of what other people have done, thinking about access to clean water in infancy, like I said, there's a lot of work on infant and child mortality, those sort of short-term impacts, which are like I said, is very established and has been done very, very well. These are very rigorous studies. And this has even been done in the context that I'll be working in. So the context I'm working in Mexico, and this program called Agua Limpia, there has been, my co-authors have shown that, again, just like these other clean water programs, you see that it has this positive impact on reducing infant and child mortality, okay? A pretty sizable impact, right? And so this feels pretty well established. What's less established is the point that we're making about how it impacts human capital accumulation, right? Really, the main paper on this topic that has been sort of held up as potentially giving some more robust evidence on this is a paper in China by Sang and Su. They find that the development of a rural drinking water program in China improved educational attainment and height. But there's some really important caveats of this paper, and there's a reason why this paper has not been cited particularly widely, and why I don't think policymakers have really started to leverage what it might be able to tell them. And one of them, the big one, is related to internal validity, in the fact that the geographic and temporal variation that they're using comes from a non-random program implementation that happened over a 20-year period. And so obviously over a 20-year period, there's a lot of opportunity for behavioral change that can undo what potentially was quasi-random to start with, right? Perhaps where they chose to put these water, where they decided to provide water, which I don't know why you'd think China would do it randomly, but even if you believe that it was done randomly, over 20 years, people are able to change their behavior in a way that would sort of undo that randomization. And that sort of concern that I have is borne out in the data, because if you look at their results, they actually find that exposure to this rural drinking water program, even starting as old as 20, increases educational attainment. And given that in rural China, at 20, almost nobody's in school, this seems problematic. You should not find that these young adults are still increasing their education because, and then claiming it's because of clean water. There's not really a lot of reason you would believe that. So that strikes us to say that there's some other selection going on that's likely generating these results. And so it's harder to take them as seriously as you'd want to. The other big part is, even if you are fairly convinced by the work, the other reason I think that it hasn't been latched onto as much by policymakers is that the setting isn't really as generalizable as you'd want. Unlike most developing countries, the main impurities in the water in China are not disease-causing microorganisms. Disease-causing microorganisms is really what we're thinking about when we're talking about unclean water in South America, Latin America, in Africa. And so most of the places that 850 million people live, we're thinking mostly about these sort of disease-causing microorganisms, the stuff that we were talking about that I started with about diseases that can cause diarrhea. Really, the primary mechanism in China is the reduction of chemical contaminants in the water, right? There's been this huge explosion in manufacturing and industry, and what that's done is it's polluted the water. And while that's quite important to China specifically, it's not exactly the kind of things that people are thinking about in sub-Saharan Africa, right? Okay, so again, we feel like there's a gap here to fill, and we think it's a really important question. And so specifically what we're gonna try to do is ask whether access to clean water in infancy has a persistent impact on physical and cognitive development, and we'll exploit the local treatment intensity from this Programa de Agua Limpia in Mexico. It's a large-scale nationwide program. It was introduced suddenly as a reaction to a cholera epidemic that was happening in Mexico's neighboring countries. It led to rapid and sizable drops in childhood diarrhea mortality, and systematically, this drop was related to pre-intervention diarrheal mortality rates. Okay, and we're going to exploit that variation, and the variation is quite intuitive in that places where the water was already clean, there wasn't a lot of diarrheal mortality. And when the program came on, it didn't have a big effect in those places because the water was already clean. The places where there already was very high diarrheal mortality rates, that was because the water was quite dirty. And so once the program came and cleaned the water, that's where you saw the biggest impacts. So it's not that all of the water in Mexico is equally dirty. And so it's not that we think that this program had an equal effect everywhere. We're going to utilize that variation to help us generate some quasi-random variation. Okay. We'll also leverage date of birth as another source of variation. So we sort of have temporal and geographic variation coming from when the child was exposed and where they were living and how intense the exposure was given where they were living. What we'll focus on is the impact of this program on height and cognition in adolescence. So we'll be thinking about these kids being exposed in infancy or in utero, and then waiting until they're 10 to 16 years old and looking at their height and cognition. We have a bunch of other outcomes we're going to look at too, but these are the ones that we think are most critical given our question. In terms of contributions, we think this is the first causal evidence of the long run impact of clean water and a clean water intervention that specifically reduces early life exposure to waterborne diseases. And we're expanding the empirical approach that you find in most of these kind of studies. Most of the studies of a positive childhood shock, health shock on long-term benefits, what we're able to do is make it a nationwide and nationally representative sample, which is quite uncommon in this kind of a literature, right? Again, since we are so interested in speaking to policymakers, it's important for us that at the very least, we think that our results are generalizable to all of Mexico. But beyond that, given that we're not just looking at rural Mexico or very specific parts of a country, it allows, we are hopeful that it allows people to feel more comfortable extrapolating these results more broadly. We're going to be using a household survey design that lets us control directly for selective mortality and fertility by using within family comparisons. This is another big advantage in that when you think there's this big positive health shock, or when you think positive or negative, when you think there's a health shock to an area and you're interested in early life health, well, if it's a big enough health shock, it may change the composition of the demographics because of mortality and fertility. Most studies have to kind of, wave their hands or try to do some bounding kind of stuff. We're going to try to control as best we can somewhat directly by only comparing within families. Okay, so if it's the case that families that are on the lower end of the health distribution, if they're having too much selective mortality, well, I'm only comparing you to your sibling who's also from a family that's from that lower end of the health distribution. Okay, so that helps us deal with not comparing two different compositionally different cohorts. We'll be looking within family differences. And given that we have a longitudinal data set that we'll be using, we'll be able to see if these benefits persist, not just at adolescence, but also into early adulthood. So we'll have the nice aspect of being able to look at 2 different points in time to try to get at something about persistence. Again, a lot of these studies are restricted through data to just look at its impact at one particular point. We're going to be able to look at 2 different points to try to see if what we find is something that is going to fade out or is going to persist. And we can look a little bit at whether these can actually lead to improved economic outcomes. The individuals are still going to be a little young to say that we're going to be able to look at adult economic outcomes. The oldest that we're going to be looking at the kids is like 17 to 23. But we can start getting an idea about completed education at the very least, and a little bit about the labor market, but you'd obviously want to be careful extrapolating too much about a 20-year-old and their economic outcomes. All right, here's the context. In Mexico, in the 1980s, diarrheal diseases accounted for 1/4 of deaths under the age of 5. So diarrheal deaths is a important factor in Mexico. And the particular timing that we're gonna be thinking about in this paper is around early 90s, because in 1991, a cholera pandemic emerged in Chile and Peru and quickly spread through South and Central America. In an effort to limit its spread across Mexico, the national government launched this Programa de Agua Limpia in April 1991. Within 6 months of the implementation, the share of the population receiving chlorinated water due to this program rose from 55% to 85%. Okay, so this is just looking at sort of the rapid implementation of this project. And you can see in blue, you've got the population numbers that are covered by PAL. And in red, you have localities. And you can see who actually has chlorinated water. And you can see how quickly this shot up. This program was, unlike maybe some other government programs, this program was quite efficiently and effectively undertaken, right? And they saw big benefits very, very quickly. And this change in the level of chlorination in the water also quickly led to real outcomes, as diarrheal deaths among children in that 6 months declined by about 37 to 48%. Okay, so very quickly, within half a year, you've got a big impact on the cleanliness of the water and a big drop in infant mortality. Okay, and as I mentioned before, as you would expect, the extent of this improvement in child diarrheal deaths was highly correlated with the pre-PAL diarrheal mortality rate. Again, as you'd expect, the places that had really bad water is where the children were dying. That's the place that you're going to see the biggest changes once PAL comes in, right? And these are just this is just visual evidence of this. Okay, on the y-axis you have the change in the diarrheal rate. Okay, and on the x-axis you just have the baseline diarrheal rate, so the diarrheal rate before PAL, and you can see places that had low baseline diarrheal mortality rate didn't see a big change. Places that had big baseline diarrheal mortality rate, that is where you see the big change. Okay, as I said, we're going to leverage this. Right? The data we're going to use comes from the Mexican Secretary of Health and the National Council on Population. It provides disease mortality by cause of death, gender, and age. We're going to focus on under age 5 mortality from diarrheal diseases. And we'll also collect mortality data for other diseases like respiratory disease and vaccine preventable disease, and we're going to use those as controls. The reason we're going to use them as controls is that infant mortality from these diseases is highly correlated with overall under age 5 mortality. So they give us a little bit of a control for just the general health environment in these places. And importantly, these diseases are also driven by several of the same risk factors as diarrheal disease, things like poverty, poor nutrition, and crowdfunding, yet shouldn't really be impacted in any meaningful way by cleaning water. Okay. So that's sort of, we're thinking about these controls as just general health trends or anything else. If you're concerned, the concern might be that pre-diarrheal mortality is indicative of a lot of things that are different about those types of localities versus localities that had lower pre-PAL diarrheal mortality. These controls are there to make sure that there aren't other jumps in general health in those poorer versus less poor pre-PAL places, right? To try to control for anything that's changing unrelatedly to clean water that is for some reason correlated with pre-PAL diarrheal rates, right? Because that's really where our identification could break down. Okay. All right. The longitudinal data that we'll be using for our outcomes is called the Mexican Family Life Survey. It's a longitudinal survey representative of the Mexican population living in Mexico in 2002. In 2002, they interviewed about 8,400 households and 35,000 individuals. It provides height and Raven matrices scores, and that's what we're going to be using as our determinants of physical and cognitive development. It also has municipality of residence information for the individual, so that's how we get location. So the level of location we'll be using is down to the municipality, which is quite fine. Obviously, though, I think what you'd recognize is that municipality of residence isn't exactly what you'd like. What you'd really like is municipality of birth, but for that, we don't have that for everybody. And you could worry that maybe using municipality of residence could lead to noise or, at worst, bias because of this misassignment of exposure intensity. And we're quite concerned with that too. Municipality of birth only exists for a subset, about 70% of our focal respondents. But of that 70%, 87% of the time, it matches municipality of residence. So most of the people that we actually know where they were born, they're born in the same place they live now. But that's still not completely fulfilling. It's maybe helpful, but it's not completely fulfilling. So we will, if I have time, I'll show you, we've done a few things to try to make you feel comfortable that our results aren't being driven by this misassignment, right? And the main takeaway is that our results are indistinguishable in magnitude from an equivalent estimate where we use the municipality of birth as the location of exposure. So if we use what we know about municipality of birth, the magnitudes are the same. Where we're really losing is power. Okay? And so that makes us feel comfortable that using the full sample is a better option for us as it increases the power without generating bias. But you know, you can be the judge of that. But I'll show you the limited sort of test that we can do to sort of prove that to you. All right, like I said, the outcomes are the score on a Raven's matrices test and height for age Z scores. Our sample is going to be those born between 1986 and 1992. Okay, so this is about 10 to 16-year-old in MXFLS1. Okay, cutting it at 1992 because we don't want to increase the likelihood of this selective fertility. PAL comes in in April 1991. So we want to be careful that our results aren't just being generated by different types of families having children. And eventually I'll show you the breakdown for the effect of each different sort of birth cohort, and also show you it's certainly not being driven by those born in 1992. Our estimate is this really horrible looking econometric specification. I will try to break it down somewhat concisely and clearly. Our unit of observation is an individual I in a municipality J, whose birth year and month T, whose birth year and month is T, who has a mom M and was interviewed in year month D. Okay, our main variable of interest, our main independent variable of interest is an interaction. It's an interaction between an indicator equal to 1 if the child was exposed to PAL since in utero, so born on or after April 1991, interacted with the municipality level gender-specific child diarrheal mortality rate across the pre-intervention years. So again, what we're doing here is saying, are you a child who is at a particularly critical period? So this in utero infant period when clean water comes, and are you living in a place where your water prior to this was particularly dirty, right? That's the interaction here. What age were you when PAL came, and how important is cleaning the water in the place that you live, okay? We separately also estimate the effect for what we consider sort of more of the partial group. And these are children that were exposed to PAL only in infancy. So they were already born when PAL came in. Now, this is a group that, given the literature on early life health and the persistent impacts of early life health, you could consider them as in a sensitive period, and so you would expect that they have an effect, but maybe not as sensitive a period as those that are in utero and experiencing this all through infancy. But you certainly wouldn't want to throw them out and call them controls, because they're still pretty young when the clean water is coming. So we're going to separate and just estimate it on its own. We're going to be non-parametric about this and say, let's look what the effect is for that group. And as I said before, we'll eventually also just do sort of an event study where we're looking cohort by cohort to see where the impact's really happening, right? We're going to control for the gender of the child, the birth order of the child. We'll control for quadratic function for the mother's age at birth. We have date of birth, date of interview, and municipality fixed effects. We will also have municipality specific linear time trends. Again, just trying to get rid of any sort of general health trends that are different in the places that the water was dirtier versus the water was cleaner. We don't want anything to be generated by that, so we'll try to get rid of any of these general health trends. Okay. This type of difference in difference that we're doing, leveraging this time and geographic variation, particularly geographic variation that comes from pre-intervention characteristics, has been critiqued as it's been more common in economics. And the big critique of it is you're using one specific characteristic, in our case, pre-intervention diarrheal mortality, as the indicator for how intense is treatment, how intense is the treatment that you're gonna be giving, okay? But if you got that wrong, and actually whatever that characteristic itself had its own impact that was differential, then you'd be calling it the impact of your treatment, when in fact it's the impact of some other trend or some other unobserved difference about those types of places, okay? And so what we do is we include interactions with lots of other pre-intervention municipality characteristics, like percent of the population with access to piped water, percent of the population with access to sewage, percent of the population with indigenous heritage, mean education level, mean log of income, with the idea of being that those are things that are correlated potentially with the pre-intervention diarrheal rate, but are not the cause of clean water. And so our interaction is meant to pick up the cause of clean water. Those others are hopefully picking up any other leftover trend that hasn't already been picked up by our fixed effect or our municipality specific time trends. These are supposed to pick up any other potential trends that are correlated with the level of disease pre-intervention, but aren't actually causally related to that, okay? So lastly, we might be worried that non-random mortality or fertility selection would generate bias in our estimates. There's lots of obvious ways you could tell that story. The big one is, I told you that the short-term studies say that there's a big decrease in child mortality. That's not going to happen randomly. So the places that are improving the most are going to have more children there that otherwise, if the intervention didn't happen, would have perished. And so the demographics in the places that are benefiting the most are changing quite rapidly, okay? And so you might be worried that would bias the estimates. Now, most likely, that bias would be against finding a long-term impact, because the ones that are going to be surviving when otherwise they would not have, we think are probably at the lower end of the health distribution. So you're sort of adding in these places that we're calling the highest treatment places, you'll be adding in more lower end distribution births, lower end of the health distribution births. And so that would actually bias us against finding a long-term impact. We're going to try to control for things like that through maternal fixed effects. Again, with the idea being that if this child who was able to survive comes from a lower end of the distribution health household, I'm comparing you to your sibling who comes from that same household, rather than to a completely different cohort where the composition mix may be very different in terms of parental characteristics, family characteristics, things like that, okay? Our standard errors are going to be clustered at the municipality level because that's our level of treatment. Okay, in terms of remaining threats to identification, I think the big one is that if there were other public health interventions, there doesn't seem to be any good suspects. I've talked to a lot of people that know a lot more about Mexico's public health history than I do, and they can't really seem to come up with any good ones. And I've asked them to try to. That said, you still might be worried that prior interventions, even if they're not happening at the same time as PAL, might cause bias if they generate differential municipality pre-trends that are correlated with that diarrheal rate, okay? And that's where we're gonna bring in those placebo diseases that I mentioned before, okay? If for whatever reason, those places that pre-PAL had the highest level of diarrheal mortality, for whatever reason, from another policy, were already starting to get better, okay? That should be picked up by these placebo diseases, okay? If there were other, since those things respond to a lot of the same risk factors as diarrhea and track really well with general child health, those things should pick up general health environment trends, with the hope that once I remove any of that, what's left over from my independent variable of interest is really only the water part. That's the idea. Okay, all right, and that just restates that. We'll also just fully saturate this just to be really annoying, and also even put in state of birth by year of birth fixed effects. Okay, so we're just really trying to be as careful as we possibly can. All right, so I'm going to start showing results, even though I know I only have 20 minutes left. I will try to go quickly. In order for you to interpret what I'm about to show you, a 1 standard deviation in the child mortality rate is 10 per 1,000, which is roughly the size of the decline nationally between 1985 and 1995. Okay, so you can basically multiply these by 10, okay, to get an idea of the average effect. Okay, all right, so if you just do a simple difference, it looks like PAL is really bad, but that makes sense because the simple difference leaves out the fact that the places that are going to have the biggest impact of cleaning water are already not doing so great. Okay, so of course you'd want to control for anything that is geographically specific. Once you do that, once you add in these municipality fixed effects, okay, that will reveal what we would expect, which is a positive effect of PAL exposure. Okay, this positive effect emerges. All right. As we continue to add these controls, so now we're going to also include those municipality-specific trends, all of the interacted trends. This positive effect only grows. Okay. And then finally, I bring in these mother fixed effects, and you see the positive effect is not the result of selection. And actually, the selection goes the way we expected. Selection was leading to an underestimate of the effect, okay, because we were including more of these lower end of the distribution individuals into our treatment cohort. And once we now only control for them or compare them to their siblings, the effect grows. All right. And so again, just to sort of have an idea of what these magnitudes mean, it's saying that a 1 standard deviation decline in the diarrheal mortality rate throughout infancy leads to a 3.4 percentage point increase in cognitive scores, which is also a 5.6% increase in cognitive scores, or a 0.15 standard deviation increase in cognitive scores. These are not small. Okay? They're not, I wouldn't say consider them gigantic, but they are not small. These are identifiable and not marginal. Okay? We might be worried this is driven by all of those different sort of general health trends. Okay, if I start putting in those non-diarrheal, those placebo diseases, put in the state of birth, year of birth, fixed effects, I just keep trying to throw whatever I can throw at it, that coefficient doesn't really budge. Okay. You might be also worried about, is it driven by municipality of residence rather than municipality of birth? That one's really a tricky one that I really don't love, that we have to deal with. Okay. So what I'm going to show you is this first column is just the main result that I had shown previously. I'm going to re-estimate this now, but only using the people in which I have municipality of birth info. Okay, so it's the exact same estimate. I'm still using municipality of residence. I'm just changing the sample. So this would what would happen if I only use the sample where I had municipality of birth. And what you see is, one, well, obviously we lose power, and the effect goes down. Which suggests that whoever this sample is that has a municipality of birth info, they are less impacted. So whatever heterogeneity they represent, it is a smaller effect. Okay, and so obviously, when I use that sample and actually apply municipality of birth information, I should expect a smaller effect. And so that's what this last column is. But importantly, you can see that there isn't any change in the magnitude of the coefficient between the second and third column. Okay. What this tells me is, yes, for those people that I have municipality of birth info, the effect is smaller, but it's not because of whether I use residence or place of birth. That has nothing to do with it. Whether I change where I assign exposure actually doesn't have an impact. If anything, using municipality of birth gives me a larger effect. Okay. So the idea would be, if I had municipality of birth for my entire sample, it would hopefully look quite a lot like that first column. There's no reason to suggest that it would not. Okay. Still probably not as satisfying as we'd all like, but that's kind of the best we can do given what we've got. Because again, we don't want to lose the generalizability of our sample. We don't want to use this very selected group. We like the idea that we have a nationwide sample that is representative of Mexico. Okay, so the best we can see, this is not generating bias. Okay, we see there's a large jump when we add the maternal fixed effects. You guys might be interested in why that's happening. I mentioned selection. Okay, and what you can see is that it's not the effect itself isn't from the sample that we're choosing. Okay, so what the second and third columns is basically saying is, if I only look at the sibling sample and it's not that the sibling sample itself is the most impacted. Like if these second and third column were really, really big, you'd say, well, the only reason that the maternal fixed effects are giving you a bigger effect is because the sibling sample has a bigger effect. Actually, it's the opposite. The sibling sample is going to lead to an underestimate of the effect. Okay. So if it's not that, then maybe it is this selection story. So what I can do is I can look at mom's characteristics. And what you see is that the mom's characteristics of my treatment cohort are women that are coming from lower per capita expenditure households. They have poor health as indicated by undernutrition. They're also, while not statistically significant, it's not a trivial lower Raven score. So the mothers of this group seem to be coming from the lower end of the health distribution. And so obviously when I compare siblings, I'm going to remove that negative bias. That's really what's generating that jump once I add in the maternal fixed effects. All right. This is just to show you the event study. Okay. Again, what you'd be particularly worried about is if everything's being generated by 1992, you might be worried about selective fertility, although it'd be a little complicated to tell the story given our maternal fixed effects. But what you can see is that in those in the areas that are having the biggest exposure to PAL, there doesn't seem to be a pre-trend prior to the individuals we think would be most exposed. Those 1990 ones are the ones who are that sort of partial exposure group where they're experiencing it in that sensitive period, but not through the entire sensitive period. 1991 and 1992 are the ones that are getting it through in utero all the way through infancy. Okay. So this to us is reassuring. So these results on cognition are really robust. It's hard to knock them down. You can include whatever you want. They don't seem to go away. Height looks very similar. Okay. The estimate for height is a 1 standard deviation change in the child mortality rate will lead to a 0.11 standard deviation increase for height for age. Okay. And again, these things are also very robust to all the different controls. That's all this is showing. Again, it doesn't seem to be generated in any way by municipality of birth versus municipality of residence, because in fact, those coefficients look very similar. Okay. And again, we don't see any indication that this is being generated by pre-trends. Okay, very flat prior, and it jumps up once we get to our actual sensitive exposure groups. All right, this is just about persistence. Okay, so this is just about the persistence of the effect. We can also, so what I was showing you is MX1. I can look at results from MX3. So these are when the kids are about 17 to 23, a little bit older. And in column 4, you can see that this effect has persisted. Okay. That the impact on height is quite similar. We had a 0.11, now we see a 0.18. And the effect on cognition is also still quite high. It was 0.34 in MX1, 0.53 in MX3. So it doesn't just seem that we got them at one lucky moment in time. even a number of years later, in the next wave, 2 waves of the survey later, the kids that were exposed in infancy to PAL are taller and score higher on cognitive assessment scores. Okay, I'm running out of time and I prefer to take questions. All of this is just talking about gender. What we find is the effect is bigger for girls than boys. It's not non-existent for boys, but it's certainly dominated by girls. And yeah, I'll leave it at that. We can also look a little bit at like educational outcomes and things like that, but I'd prefer to take some questions. Sorry again for being late.
Thank you so much, Ryan, for sharing your interesting work and for making the pivot from your family-related hat to
Yeah.
to your water cleaning hat. This is really interesting. So I'm sure it inspired a lot of questions. We can take those. I'm looking at the chat box here and seeing some roll in. So we can turn to Colleen Reed first. Colleen writes, what if the people for which you have municipality of birth info are more likely to live near where they do now as compared to those for which you don't have municipality of birth information? How might that affect your results?
Yeah, I think that that's an excellent question and intuitive. I mean, that makes sense to me that could be a big reason why we see the overlap between the ones I have municipality of birth information. They seem to be still living in the place that I have as their municipality of residence, right? So I said maybe that's reassuring. I think you're saying that that's maybe a selection. There's a reason for that selection. I think you're probably right. In terms of how it would affect the estimates, that I think is quite complicated because you'd have to tell a story about how these individuals are moving. They're moving from one type of place to another in a way that would generate the results that we're getting. So it would have to be something like the higher ability families or individuals, because this is within a family, right? So it'd have to be that the higher ability individual in that family has moved to a worse location, because the places with the higher intensity are the worst locations. And so it kind of goes against what you'd expect in terms of selective migration. What I would expect is if our treatment is making the kid better, they go to a better place. But that's going to work against us because now in municipality of residence, it's going to look like low treatment and high ability. Okay, so I'm certainly not saying we can tell stories. I am known for telling some strange ones that can fit whatever bias you're looking for. But it would feel like it's not an obvious story to me. Would love to hear if anyone does feel like there is a potential selection there that I might be missing though, because that might lead me to figure out a way to test for it.
Just to follow up on that a little bit, Lori Hunter asked if you know what underlies the difference in data availability regarding municipality of birth. So is that something that's baked into the study design, or how does that work?
So what it is the biggest reason is that there are many names that, so municipality of residence is done with a code like state 10, municipality 54. The municipality of birth, because it was taken in a different part of the survey, is actually written down. So there are a lot of misspellings. And so many of the misspellings I can clean up, or there's actually one other place I can get municipality of birth information from, so I can sort of cross-reference them and do my best to clean it up. But there are just some that are so poorly misspelled that it's really hard to figure out what they were intending. And so this is another reason I feel, so this is one I don't share as much because it very much is like a feeling. I feel that most of the error is, or the loss is coming from random misspelling, or that just some places are harder to spell than others. And it's hard for me to think of why that would be correlated in a way that would generate bias. But I don't want to lead with that because, I have no way to prove that. But it is, most of those missings isn't because they're actually missing. It's because I can't figure out what they're referring to.
Wondering if you can go back to the gender differences we didn't have time to discuss. Steph
Yeah.
Mulburn asked if you might opine on that for a moment. So what do you make of those effects?
Yeah, that's a really interesting one too. So the first thought would be that perhaps the impacts of clean water were not shared equally between the genders. Perhaps you can imagine a situation where, like, if it's a male dominated society, even if there's bad water, I'm making sure the male child is healthy. So even in those bad places, the male was protected and the female wasn't. So when PAL comes in, it ends up impacting the girls more. But if you look at the child mortality, the infant mortality results, they don't seem to differ by gender. So that protective story of the boys were more protected than the girls isn't at least obviously found in the data. Because if that was the story, you would expect the mortality gains to also be amongst girls and not boys. We don't see that at all. One of the very strong opinion of one of my co-authors is that this is much more related to the way that the Mexican economy has been changing over time, that it's become a more service-based and cognitive-heavy economy. And so for a long time, there was unequal investment between the boys and girls because there was a lot of economic gains to be had from stature and physical strength. And as that pendulum swings more to cognitive ability, there is a higher return to investment in girls. And so we show a little bit of evidence of that in the paper. You can see sort of the economy is changing over this time period from a more physical stature based economy to something that is relies more on cognitive skills. But again, that is very much an opining. It's very hard to generate precise mechanisms for that. We also tried to look a little bit about like parental investment, if it was something about shifting parental investments. One, the data on that is just unfortunately pretty scarce and not, it doesn't ask the kind of questions you'd maybe ideally want. But from the limited thing we could see, it may be tilting the scales a little bit to this more investment in the girls than previously, but it's not, doesn't jump out at you, I would say. So unfortunately, it is a piece of the paper that is there and we think it's interesting, but we don't have a good answer to that question.
Fernando, I'm going to try to paraphrase your comment and question, but Fernando writes that it seems that the changing the composition of the population is an actual impact and should possibly be counted and treated as a source of heterogeneity of impacts as opposed to a source of bias. So he's wondering if you could say a little bit more about why selective lower mortality in particular due to the program is a source of bias in the estimates. How did you come to be focused in on that as a source of bias?
So the way I would consider it is it absolutely is a cause of the program and it's an important outcome. And there's a separate paper written specifically about that outcome, this change in the child mortality rates. But if you were trying to specifically ask the question about the impact of clean water on cognitive development or physical development, we don't want that mortality biasing that effect. That effect may be the overall effect you get in Mexico, but in terms of generalizability, we don't necessarily want to say this is the causal effect of water because it's the causal effect of we don't want to see causal effect of water in the sense that that would be mixing its compositional effect with the actual impact it has on human capital accumulation. And I think in this paper we're focused on the human capital accumulation part rather than the compositional change. And so I think it just answers maybe a slightly different question. And the nice part is that both results are in there. So you can see the results with and without. And in both cases, they're quite positive and significant. So if you were trying to think about introducing this program, what is the overall impact it's going to have on the economy? You'd probably want, as Fernando is saying, you'd probably want the effects that include the compositional change, because that is the overall economic effect. But if you're interested in what is the causal effect of the water itself, the cleaning of the water itself on their cognitive and physical development, you want it out of there, right? Because that piece of it, the compositional change isn't about their physical or cognitive development of the child itself, right? You'd want to be comparing that kid who to somebody that looks very similar to them and didn't have water. And that's what the family fixed effects are trying to accomplish for us.
Sorry, I muted myself. We might have time for just one more request. Solveig Dalabroy asked if you could share the results briefly on educational achievements. Do you think we can squeeze that in real quick?
Yeah, are you guys still seeing my screen?
We are.
Okay, cool. So here are the results in MX1. So this is when the kids are 10 to 16 years old. And these are results on years of education, whether they attend school, whether they have repeated a grade, whether they've started secondary school, because that 10 to 16 area is right around when they would be doing that, and whether they're in the labor market. And you can see that this improved cognitive physical development does seem to be improving achievement of education. It's not really changing whether they're attending school or not, but it is what it says to us is, given that there's more years of education and less repeating, they're both in school, but one of them is actually progressing through school, whereas the ones who did not get this benefit are sort of lagging behind. And what we also like here is that maybe something about returns to investment, they're not leaving school for work. Okay? Even though they're both physically stronger and cognitively stronger, they're staying in school, hopefully with the sense that that means that they understand that there's an understanding that they are doing better. And so if we keep them in school, this in the long term will be better for the entire family. I can also show what that looks like by gender. And what you see is that what's interesting is that while the cognitive and physical development stuff was stronger for girls than boys, there was still a smaller effect for boys, but much stronger for girls than boys. This effect on education that I'm identifying here is very much dominated by the boys, which maybe suggests something about the fact that they were the ones that were more likely to be pulled out to go into the labor market, or potentially some of the cognitive development stuff also spills over into behavioral things, and that was leading to repeated grades and things like that. And then this is just showing the long-term effects. This is MX3 now, years of education. So what we see is that increase in the years of education, one, we have a less power in MX3, but it definitely fades out, which suggests that while what we saw was the kids were progressing faster, eventually the kid gets there, the other kid gets there, they just get there slower. That's what it looks like comparing MX1 and MX3.
Nice, thank you very much. I was asking because I'm working on a fairly similar paper in Bangladesh, and our main outcome of interest was years of education. So I kind of wanted to have an idea.
It's a really nice one to think about. I think it gets complicated in certain places, because if the physical development is so much better now, they might leave school because the economy may be very rural, and so, oh, you're really strong now, you don't go to school anymore. And so we've always it's been complicated for us to think about how to manage something like years of education.
Yeah, for sure.
Okay, we are right at time now. So using whatever virtual method you please, join me in thanking Ryan Brown for presenting his fascinating work. Ryan, thank you so much.
Thank you guys so much for spending the time. I really appreciate it. And definitely feel free to reach out to me with any other comments or suggestions or research stuff you want to talk about, or you have for me, whatever. I'm here with my kids, but I'm here.
Brian, thanks so much. And thanks to all for joining today.
Thank you.
Yeah. Thank you, Ryan.